So the objectives here, what I'm going to do is, as background information, talk about the ASA closed claim studies, highlighting the airway issues related to extubation and emergence, and then talk about the latest practice guidelines that was published last month, the 2013 ASA practice guidelines, and the recommendations on the strategies for extubation and of the difficult airway. An equally important document is the 4th National Audit Project, and this project was published not too long ago in 2011. And then in relation to that, talk about the emergence, extubation and emergence issues, and the Difficult Airway Society guidelines for extubation and recovery. Now, this is very important to have a framework for the next issue that I'm going to talk about, and that's going to be the main focus. And that's the maternal mortality issues related to extubation and emergence, discuss the risk factors and the inadequate management or the systems issues that led to the maternal deaths, and then discuss the strategies using the framework of the ASA practice guidelines, the Difficult Airway Society guidelines, using that framework in order to provide safe and optimal care so as to avoid maternal deaths. Now, we all know that airway management is a continuum of patient care during intubation, maintenance of anesthesia, and evaluation. But the practice guidelines that was published in 2003, the ASA task force paid much attention, rightly so, to the difficult airway management during induction and intubation. And there's very little emphasis on management strategies focusing on complications following tracheal extubation. And there's a statement in there, and again, even in the 2013, they allude to this statement here, that there's insufficient literature to support the merits of an extubation strategy in the general surgical population. However, the closed claim studies, the ASA closed claim studies was published in 2005, and Dr. Wally will be talking about the closed claim studies, but just to let you know, it takes a while for the malpractice case to settle and then for it to be published. So in this here, the research that was done, they looked at closed claim studies, they looked at the closed claim studies prior to 1992 and compared it to the claims, that is, claims and the deaths and brain damage following between 1993 and 1999. And what they found was actually that the incidence of death, the claims and death and brain damage had increased dramatically following extubation and emergence. And they were mainly due to problems of extubation and emergence in morbidly obese individuals and individuals with obstructive sleep apnea. And you can see that this is going to be the recurring theme in everything that I'm going to present. So, in the latest practice guidelines, if you haven't read it, it was published in the February issue of Anesthesiology. The ASA Task Force on the Management of Difficult, this is the statement that they have. The ASA Task Force on the Management of Difficult Airway, now this is what they're stating, regards the concept of extubation strategy as a logical extension of the intubation process. So we keep talking about strategy. So what is strategy? It's a clear decision, and in this case, extubation, and it's a statement about a chosen course of action for obtaining a specific goal or result. So in the extubation strategy, what's going to happen is we are going from a very controlled situation where we have a tube in, we are controlling the ventilation, to removing the tube and hoping that the patient can maintain the airway. So we have to have clear strategy as to how we're going to manage that. So this is new information that was published in the 2013 practice guidelines. Now they have recommendations for extubation. The anesthesiologist must have a pre-formulated strategy for extubation of the difficult airway. Now remember, this is only for difficult airway. They're not talking about other kinds of extubation in other patients. The strategy will depend on the surgery, the condition of the patient, and the skills and preferences of the anesthesiologist. And in this case, I would say even in the CRNA as well, because we function as an anesthesia care team. The recommended strategy for extubation of the difficult airway includes consideration of the relative merits of awake extubation versus extubation before the return of consciousness. This is in a difficult airway. Also, one has to consider the general clinical factors that may produce an adverse impact on ventilation after the patient has been extubated. But the next two statements are very important. An airway management plan that can be implemented if the patient is not able to maintain adequate ventilation after extubation. And this is what they're recommending. Short-term use of a device as a guide for expedited reintubation. And the things that they're recommending are stylets or intubating bougie with a hollow core that can be used to provide temporary means of oxygenation and ventilation. Now, this is also a very important publication, the 4th National Audit Project. If you haven't heard it, you're going to hear a lot about this, the NAP4. It was a UK study of major complications of airway management in anesthesia. And what they found was that almost 1/3 of airway events occurred during anesthesia, occurred during emergence or recovery. And majority of these adverse outcomes were due to airway obstruction being the cause of death in all of these events. So immediately, that was published in 2011, immediately the Difficult Airway Society, very much like we have the Society of Airway Management, they went to work and they developed and published the guidelines for safe management of tracheal extubation. And the approach that they used here is very much like the difficult airway guidelines that they had published earlier, the 4-step plan, because it's easy to recall and easy to implement. So step 1, they said plan the extubation. Identify, here you have to identify risk factors. Step 2 is prepare for the extubation, again based on the risk stratification. And step 3, if it's a patient who is at low risk, that is, there are no risk for complications, then either a deep extubation or an awake extubation. However, if you have a patient who's at risk, very much like the practice, ASA practice guidelines, if you have a patient at risk, then you have to ask the question, is it safe to remove the tube? So what are those at-risk patients? Pre-existing abnormalities, if you have an anticipated difficult airway or you encountered an unanticipated difficult airway, obesity, OSA, patients at risk for aspiration, or perioperative deterioration in the condition, an airway that was normal at induction becomes difficult, distorted anatomy, hemorrhage, edema from surgery, or restricted airway access. It might have been easy before, but now there's halo fixation, mandibular wiring, cervical fixation, or surgery implants. So in this sort of patient, then you have to consider, is it safe to remove the tube? If you say yes, then it's awake extubation. Or advanced techniques. What they do in the UK is the so-called Bailey maneuver, where they have the patient breathing at the end, towards the end of the anesthetic, and then place an LMA behind the tube, suction the patient, remove the tube, and then inflate the LMA, and that stays in. And it's been shown, even with studies, that is a superior, using the Bailey maneuver, it's a superior technique to deep extubation or awake extubation, particularly when you have the type of surgery where you do not want the patient to cough or buck. Or the other advanced technique is to use the airway exchange catheter, and I'll talk a little bit more about this. If you say it's not safe to remove the tube, then you postpone extubation, or if there's a lot of head and neck surgery, then tracheostomy is indicated. So let's focus on maternal deaths following extubation and emergence from anesthesia. So we're going to use that framework from the ASA practice guidelines and the recommendations for extubation strategy and the difficult airway society guidelines from UK and see how we can apply it here. So this was Jill Meyer's study, and Dr. Vallejo mentioned a little bit yesterday. They looked at the maternal mortality in Michigan. There were 855 pregnancy-associated deaths. 8 were anesthesia-related, 7 were anesthesia contributing, and the anesthesia-related deaths accounted for 2.3% of pregnancy-related deaths. What they also found in this, and it's another very important publication, the anesthesia-related deaths occurred post-operatively during emergence and extubation and emergence and post-anesthesia recovery, not during induction of general anesthesia. Again, recurring theme, cause of death was airway obstruction and hypoventilation. They also found that there were system errors. There were lapses in postoperative monitoring. There was inadequate supervision by an anesthesiologist, and obesity and African-American race were important risk factors for anesthesia-related mortality. If you look at this table, you can see, if you look at the BMI here, majority of these patients had a BMI greater than 30. And again, majority of the patients that died were either African American or Hispanic. And the cause of death, again, majority of these cases was airway obstruction or hypoventilation. So this statistics is from one state. So we don't know what's happening in 49 other states, and this could just be the tip of the iceberg. So what about in UK? Confidential inquiries into maternal deaths, they keep the most accurate data of all maternal deaths. So between 2003 and 2005, there were 6 maternal direct deaths attributable to anesthesia care. 1 resulted from respiratory distress or extubation, and 2 from postoperative respiratory insufficiency. So out of the 6 deaths, 3 deaths, 50% of those deaths were related to following extubation, and they were immediately postoperatively, and these deaths were due to inadequate supervision, postoperative hypoventilation and failure to monitor adequately, failure to adequately manage the airway and ventilation, and morbid obesity in 4 out of the 6 deaths. Then the subsequent triennium, every 3 years they put out the data. So the confidential inquiries into maternal death between 2006 and 2008, there were 7 anesthesia attributable deaths detailed in this report. 1 death was persistent intubation attempts despite adequate ventilation through the LMA, and 1 death was from aspiration following extubation, and that patient was recognized to have a full stomach. What about the Canadian data? Between 1990 to 2000, there was 1 anesthesia attributed direct maternal death, and this 1 death occurred postoperatively following extubation of the trachea. So let's focus a little bit on the risk factors. Obesity has been identified to be a risk factor. 2 days ago, while I was here at the hotel, I was listening to the news, and from the Mayo Clinic, they've come out, and if you look at the overweight, the BMI, they were saying that 70% of the US population now is overweight. Class 1 is above 30 BMI, Class 2 is above 35, Class 3 is above 40, and above 50 is considered super obesity. If you look at the year here and look at the color code, and you can see that over the years, we're becoming more and more obese. And so here we are, 30% of the population in the United States are considered to be obese. 70% are overweight and 30% are obese. So we are seeing more and more obese parturients in our labor and delivery. It's also projected, and this is from the CDC, that if we continue on the same trend, that by the year 2025, 50% of the population is going to have a BMI greater than 30. So also here, if you look at the prevalence of obesity, besides it being an epidemic worldwide, that it's higher in women than men, African American, if you look at the pink bar here, it's more common in women. And again, African American population had a 51% higher prevalence of obesity. Hispanic population had 21% higher prevalence. And the prevalence of obesity, 30%, above 30 BMI, and no pun indicated, has the greatest growth this past decade. And obesity is now the leading cause of death. And as Dr. Vallejo pointed out, there's a high prevalence of comorbidities. So getting back to the Michigan study, majority of those deaths, again, African-American women were noted to be at an unacceptably high risk. There were increased rates of chronic hypertension, gestational hypertension, preeclampsia, obesity, obstructive sleep apnea, and peripartum cardiomyopathy. And they were more likely to deliver by cesarean, therefore they are more likely to require an anesthetic. And of course, they pointed out medical errors and management problems. So should we have a strategy? Remember, with the ASA practice guidelines for difficult airway during induction and intubation, not all of it can be applied to a pregnant woman because we have to take into consideration the fetus and the status of the fetus. But here in the PACU, the parturient has already delivered. So what should our strategy be? Should we apply the ASA practice guidelines? And remember, you're going to say, oh, that was only in Michigan, or there's only one death, or only 7 deaths. But the impact of even one maternal death due to airway catastrophe is enormous in terms of its devastating effect on the family and the financial liability in obstetric-related claims. Equally important goal should be, and the anesthesia community, the obstetric anesthesiologists have worked very hard to really decrease maternal mortality, and then when you're going in and you're administering an anesthetic, so the complications from induction, intubation, and the obstetric patient has declined. But our goal should be to entirely eliminate airway-related maternal adverse outcomes, including during extubation. However, again, having stated that, just like the ASA closed claim studies had stated, there is insufficient literature to support the merits of an extubation strategy in the obstetric patient. So what should our strategy be? So remember that step 3, where you're planning or you're actually performing the extubation. So in those patients or parturients who are at risk, and at risk meaning they've had a difficult airway, abnormal airway, morbidly obese, obstructive sleep apnea, African-American women with preeclampsia, the incidence is high of preeclampsia with edematous airway. What should you be doing? And let's say, majority of the time we're going to try and do regional anesthesia, but let's say one of these parturients did receive a general anesthetic. Then according to both ASA practice guidelines as well as the difficult Airway Society guidelines, you must maintain a conduit within the trachea with an airway exchange catheter in these at-risk patients who are likely to have airway-related complications. This AEC allows the feasibility, and that's what the practice guidelines said, AEC allows the feasibility of resecuring the airway and would add to prevent to patient safety. So I had put this lecture together 2 years ago, before any of these practice guidelines had come out. So it's heartening to see that that's what these practice guidelines are saying that you need to do. So considerations for reintubation over the ASC, when would you consider placing or doing using the endotracheal tube over the ASC? Patients who become hypoxemic when the saturation is less than 90, or severe hypoxemia when the saturation is less than 70, shortness of breath, tachypnea, increased work of breathing, increased end-tidal CO2. The type of ASC, airway exchange catheter, it's a Cook catheter, 11 French. The length of time to leave it, this is not evidence-based, but just arbitrary recommendation based on Dr. Tom Mote's study. and he's done extensive studies on extubation. He recommends it varies from 30 to 60 minutes or up to 2 hours. And the Cook catheter can be placed on the side, and you can tape it to the cheek. It also has a little adapter where you can administer oxygen through it if need be. And it allows the feasibility of resecuring the airway, and again, would add to patient safety. So how do we know that the AEC works? This is again from top-most study from the ICU. So we take the lessons that we learn from there and apply to a situation that we may encounter. So patients that had an AEC versus that didn't have, when they had the AEC in place, the first pass success rate for reintubation was very high. Those that didn't have the AEC, the hypoxemia during intubation, the incidence of that was very high. Severe hypoxemia was high, bradycardia was high, and then if you look at this here, multiple attempts, including the use of accessory airway device, was high in those patients that did not have an AEC. Esophageal intubation or the use of the rescue airway device technique was also high in those patients. Then this is based from the DAS, or Difficult Airway Society guidelines. So what's the sequence for use of an airway exchange catheter for reintubation? And we know these patients, majority of them are obese, so have them positioned appropriately on a ramp, apply 100% oxygen with CPAP via face mask, select a smaller tracheal tube with a soft, blunt bevel tip, very much like the tube that you use through the intubating LMA or the fast track, and then administer either an anesthetic. And please read this document. It's really very nicely described how they use remifentanil infusion or topical agent as indicated. And of course, it all depends on the condition of the patient and what's going on. So use direct or video laryngoscope, like Dr. Tom Mort has used a video laryngoscope to retract the tongue and railroad the tracheal tube with the bevel facing anteriorly over the AEC. So after reintubation, confirm the position of the tracheal tube with capnography. Now, what about step 4? And step 4 in the DAS guidelines recommends a number of things: oxygen, the monitoring, the supervision, the handoff. So what should we do here? So establish protocols. Remember, in a labor and delivery setting, and as Dr. Carvalho said, can be very chaotic, or there are a lot of family members, and usually it's a birthing facility where you have the LDR concept. They go back to the labor room to recover. The same protocols should be applied here as well, particularly if you have an at-risk patient. Maybe that patient should go to a regular recovery room. You must have adequate supervision of obstetric patients by appropriate anesthesia personnel, just similar to the surgical patient. Have, if it's a PACU in the labor and delivery, have adequately staffed recovery room nurses who are capable of receiving and caring for these patients, especially following a major regional anesthetic or general anesthetic. And it should be same. They should not be a second-tier kind of provision of care. It should be the same. And the availability of properly equipped facility in the obstetric PACU. So what sort of monitoring should we use? Pulse oximetry, it's the standard of care, and that's what the ASA says, right? So there should be special focus on reducing the risk of airway obstruction and hypoventilation. Post-operative monitoring, the ASA guidelines states that pulse oximetry monitoring with monitoring the oxygen saturation is associated with early detection of hypoxemia during emergence and recovery, and particularly in the African-American population, in whom cyanosis may not be detected visually. So is pulse oximetry adequate? Because we know that the common theme of preventable deaths is OSA, hypoventilation, respiratory obstruction, morbid obesity, respiratory depression, and arrest after excessive opioids. And we know all of us have worked in the ENT room, so you can provide apneic oxygenation, and it's a while before the oxygen saturation can drop, right? So even though oximetry provides an excellent means of oxygenation, studies show that it doesn't provide and adequate monitoring to let us know that the patient is ventilating adequately. So is respiratory rate enough? And here you have 2 patients with respiratory rate is same, 12, but in one patient the tidal volume is 500, the other it's 200. And if you look at the alveolar ventilation, it's 4.2 versus 0.6, and you can see the CO2 in the patient who has a low tidal volume, the end-tidal CO2 is 70. So that's an impending disaster waiting to happen. So respiratory rate alone, it's not enough. So can we make the case for end-tidal CO2? And again, number of studies, and this is just showing a small cross-section of it, respiratory depression is the #1 reason for codes in hospitals, and it's the most common antecedent of in-hospital cardiac arrest. And this is from ASA, a review of post-anesthesia oversedation claims. Data from the ASA estimates that 62% of the events could have been prevented with better monitoring. And so number of societies and regulatory agencies, including ASA Joint Commission, the Anesthesia Patient Safety Foundation, and the Institute of Safe Medication Practices, all recommend or state that the importance of monitoring of adequacy of ventilation should be done because, and it's recognized by clinical studies, that this perhaps might prevent the deaths. So what do we have? What's the latest? We have Microstream capnography with integrated pulmonary index. It provides accurate physiological respiratory rate, adequacy of ventilation by a numeric value for the end-tidal CO2, and it gives you a breath-to-breath waveform that indicates any respiratory conditions such as hypoventilation, apnea, or airway obstruction. So it's got built-in alarm systems, the SARA, the Smart Alarm Respiratory Analysis. It takes 4 parameters, and that's end-tidal CO2, respiratory rate, pulse rate, and saturation, and gives you the integrated pulmonary index. With this, you can recognize and reduce clinically, and of course it has respiratory alarms, which kind of tells you that the patient is not ventilating adequately. So if you look at the IPI, if it's 10, it's normal. 8 to 9, it's within normal range. 7, you better pay close attention to the normal range should be around, or at least it should be above 8. 5 to 6, it requires attention and may require intervention. 3 to 4, it requires intervention. If it's 1 to 2, it requires immediate intervention. So we are not quite there with regards to end-tidal CO2. In our PACU, for our general surgery patients, or at least on our floor, we have 1 or 2 beds where we can monitor the end-tidal CO2, but we don't yet have the capnography, the smart capnography. However, at our VA hospital, they've already implemented this. So what's the future in select patients with smart capnography? Will it become the standard of care? We will require multi-institutional research trials to assess the validity of the smart capnography and monitoring the end-tidal CO2 in order to improve the patient outcomes. So in conclusion, I would say that the general anesthesia-related maternal mortality during induction has declined, and that's good news. But there's recent heightened awareness that another airway-related problem in obstetric patients is emerging, and this is following extubation and during emergence from anesthesia and recovery in the postoperative period. So each anesthesia practice must have extubation strategy, especially in the at-risk patients, and in these at-risk patients have strategies to reestablish the airway, perhaps using an airway exchange catheter, establish protocols for adequate PACU care, have appropriate qualified staffing and availability of equipment in the post-anesthesia care unit, and monitoring of oxygenation, respiration, and adequacy of ventilation perhaps is very important. I want to thank you for your attention.